In the last lecture regarding the knee, we ended with MCL injuries, and now we're going to move on to meniscal injuries. And some of this is a review from our discussion of cartilage healing earlier this semester. Now recall that meniscal cartilage is used for extra stability and load transmission, and to reduce joint stress. Some common tears that occur are seen on the slide. A is referred to as a bucket handle, B is referred to as the parrot beak, and C the longitudinal tear. We can also have what are called flap tears, where there is a piece that's still slightly attached but loose on one end. Now we can injure meniscus with a sudden trauma, and this is most common in young adults, or degenerative changes, which is most commonly seen in elderly. The mechanism of injury for traumatic meniscal tears can be a non-contact weight-bearing injury where there's a combined force of knee flexion, rotation, compression, and shear force. With degenerative changes, there's a gradual onset, so the cartilage wears out slowly, and it may be even an insignificant activity, such as bending to pick up something off the floor, that precipitates the injury. Now, during the clinical exam, one of the common complaints of somebody with a meniscal tear is that they have a locking sensation. There will also be pain and swelling, but locking sensation indicates that there's a meniscus problem. You'll see a list of special tests on your slide here: the Apley's compression and distraction test, the McMurray's test, the bounce home test, and the Thessalay test. And I'll show you these when I return. Management of meniscal injuries is dependent on the severity and location of the tear, and it also is dependent on if other tissue damage occurs, such as a ligament tear. Now you'll recall from our discussion on cartilage healing that in the knee meniscus there's 3 zones: the red on red zone, the red on white zone, and the white on white zone, as depicted in this slide here. Again, if there's a damage to the meniscus in zones 1 or 2, these are considered repairable because there will be an inflammatory response and a healing process. However, those in zone 3 are usually just removed. So the differences here are between a repair and a meniscectomy. With rehabilitation after subtotal or total meniscectomy, the person will be weight-bearing as tolerated, progress to full weight-bearing as quickly as symptoms allow. They may have a brace initially, and physical therapy will include pain management and swelling control, along with the progressive strengthening activities. There should also be range of motion exercises progressed, but there should be avoidance of full flexion in the maximum protection phase. In the moderate protection phase, we will begin to advance closed kinetic chain activities with caution, and we must be aware of changes in swelling, pain, and locking. Some closed kinetic chain exercises include step-ups, wall squats, leg presses, and stair steppers, and this promotes co-contraction and stimulates mechanoreceptors. We will also begin proprioceptive exercises and isokinetic training if available. These activities will be advanced in the minimum protection phase, and we will work on gait normalization as well as advanced functional activities. When we're talking about a meniscal repair, the difference between a meniscal repair rehabilitation and a subtotal meniscectomy includes a more gradual progression of weight bearing to allow the sutured meniscus to heal. So usually there's non-weight bearing progressed to full weight bearing within 6 to 8 weeks. Non-weight bearing early avoids vertical compression, which may disrupt healing. In the case of repair, we may use a range-limiting brace that limits flexion to approximately 90 to 100 degrees for up to 4 to 6 weeks, and closed kinetic chain exercises are not started until 8 weeks post-operatively. Weighted and full squats must be strictly avoided for up to 3 to 6 months. So the physical therapy rehab techniques are similar. It's just that with a repair, you have to wait much longer for weight-bearing and closed kinetic chain activities. And again, depending on if there's other soft tissue damage, such as a ligament tear, this may affect the rehabilitation program. One other surgical procedure that's used far less often is a meniscal transplantation. This is where the damaged meniscus is replaced by allografts, so tissue from another human. This is indicated for use if someone has had a prior meniscectomy, is still having continued pain, and has difficulty with normal alignment and joint stability. This is for somebody who's younger who does not have arthritis. In such cases, there's excellent results in pain relief and function. And rehabilitation principles are very similar to that of a repaired meniscus. So there's a very conservative approach with avoiding non-weight bearing and limiting flexion for a very long time. As you can see on the slide, you're not running until 4 to 6 months after activities, and full activities are 6 to 9 months after surgery. Now let's move on to articular cartilage lesions and recall that the function of articular cartilage is to protect the subchondral bone and reduce friction of the joint. If you'll recall from our discussion on cartilage healing, we talked about surgical options, including arthroscopic debridement, microfracturing, grafting, and implantation. So you can review those concerning surgical procedures. Now in postoperative rehabilitation, we want to minimize weight bearing if surgery performed on the weight bearing surface of the tibia or femur. So we will be non-weight bearing for 2 to 8 weeks depending on the surgical procedure and amount of damage. We may want to use a CPM, and full weight bearing is avoided for 8 to 10 weeks and relatively limp-free. We want to progress exercises from bilateral to unilateral in nature, and we want normal gait and full range of motion in 2 to 6 months, and return to sporting activities in 6 to 12 months. If they're high-impact sports, it'd be closer to 12 months. We also have articular cartilage on our patella, so there are patellofemoral pathological conditions which we need to discuss, the most common being tracking disorder, and this results in retropatellar degenerative joint disease causing pain and dysfunction. In order to effectively treat these types of disorders, we have to understand the integrative function between the hip, foot, and ankle. And we also have to understand the soft tissue surrounding this area. So in your slide, you'll see during a physical exam, we may be looking for excessive hamstring tightness, rectus femoris and iliotibial band inflexibility. We may examine the Q angle, and we may look at the miserable malalignment syndrome, which I'll be more specific about in just a minute here. Patellar tracking disorders are one of the most common disabilities of the knee, and the symptoms include anterior knee pain with prolonged sitting, stair ambulation, and squatting motion. So now let's look at the bony and soft tissue contributory issues to patellar tracking disorders. First, we'll look at the position of the patella. We have patella alta, the normal position of the patella, and patella baja. Now, patella alta, so that's a patella placed more proximally, is associated with instability. This will be something that the physical therapist examines. Q angle, which you see on the left part of this slide, is an assessment tool that relates to tracking and the line of pull of the quads on the patella. Now, I think you may have done this in a class, but what you do is you take a line from the ASIS to the mid-patella, and then you take a line from the tibial tubercle to the mid-patella, or tibial tuberosity, and you create an angle here, and you can see this on your slide. You measure that angle. The average Q angle in males is 13 degrees, and in females 18 degrees. If the Q angle is greater than 14 degrees, it indicates a tendency toward instability. If it's greater than 18 degrees, it indicates a tendency for patellar dysfunction. Because of the normal angle in the female, females are more susceptible to tracking disorders. Another bony issue contributing to tracking disorders is what's called miserable malalignment syndrome, and you can see this in your slide here. Miserable malalignment syndrome is characterized by femoral anteversion, squinting patella, proximal tibial external rotation, and foot pronation, and it results in what we call the bayonet sign, if you can see this slide here. You can see that the angle of pull on the quads to the tibia is quite different than in the normal alignment, and this contributes to tracking disorders. There are also muscle forces that contribute to anterior or retropatellar knee pain, and these are typically excessive hamstring tightness, because this increases the patellar compression, because the patellar excursion through knee extension is resisted by the hamstrings, requiring more quad force. In addition, you'll often see that VMO weakness, or vastus medialis oblique, is noted as a contributory factor. In addition, tightness of the iliotibial band and the tensor fasciae lata is also seen as a contributing factor, as is tightness of the rectus femoris. So in the case of these muscle forces, we would want to stretch the muscles that are tight and strengthen the muscles that are weak. Special tests used for examination of patellar tracking disorders include Noble's compression test and Ober's test. And we've had Ober's test before, but I'll show you both of these when I come back. Now, with respect to rehabilitation of non-operative patellofemoral disease causing anterior knee pain, the key to treatment is to strengthen the tissues that are weak and lengthen the tissues that are tight. And we've talked about this previously. There also may be use of supportive bracing and taping and kinesiotaping and thermal modalities to decrease pain and edema. Now, as we stated, the VMO is often considered a contributory factor to this problem, so there are some exercises that can target the VMO. These include quad sets with biofeedback, and straight leg raises and short arc quads with 10 to 15 degrees of lateral hip rotation. Also, we may target the hip adductors. Stretching exercises will include IT band stretching, hamstring stretching, and manual patellar stretching. Early on in rehabilitation, we may want to modify the activities, for example, stair climbing. We may want to instruct our patient to ascend and descend each stair leading with the unaffected leg. This will decrease the compression forces on the affected leg. And of course, if the rectus femoris is tight, we'll want to do stretching for this soft tissue as well. If conservative treatment is not effective, there are operative treatments for this condition. We've previously spoken about articular cartilage saving, and this is used for chondromalacia. So we smooth out the areas of the patellar that have been degenerated. We can also use perforation or abrasion chondroplasty, again to stimulate the inflammatory process. But in severe cases, we might do either a proximal realignment or a distal realignment. In a proximal realignment, the retinaculum is released with or without VMO advancement. And in a distal alignment, we move the tibial tubercle, where the quad insertion is, to a more advanced position. You can see in your slide, this is the retinacular release on the left, and this is the shifting of the tibial tubercle on the right. So the idea of both of these surgical techniques is to change the line of pull of the quads. So you can see in the retinacular release, we're trying to make this side looser so we have a little bit more medial tracking. And the same with this condition, we're trying to change the insertion site so there's a better line of pull. Rehabilitation following a proximal realignment includes swelling management, and this is essential to limit adhesions. If the VMO is advanced, there must be care to let this heal before VMO contractions occur. And we want to keep the lateral structures flexible. Rehabilitation of a distal release requires bone healing because we've moved the tibial tubercle, so the person may be in an immobilizer or a hinged brace for up to 4 to 6 weeks. There may be non-weight bearing progress to full weight bearing over approximately 6 weeks, and range of motion may be progressed up to 120 degrees over 6 weeks. In this case as well, quad exercise is deferred for a few weeks to let the insertion site heal. Rehabilitation after articular cartilage shaving includes non-weight bearing to toe touch weight bearing in about 4 to 6 weeks. For about 4 to 6 weeks. And you must continually always be watching out for pain and crepitus with any of these surgical procedures. Now let's look at some common fractures of the lower extremity, and we'll start with patellar fractures. And you can see in your slide a variation of different descriptions. We have an undisplaced, so just a crack in it, a transverse, lower or upper pole, comminuted, and vertical. Patellar fractures can occur from direct trauma, but also from indirect trauma with a violent quads contraction, and I've experienced this myself. If it's non-displaced, it is casted in extension. If it is displaced, it may use an ORIF procedure shown in the slide where there's tension wires. This may be immobilized in 20 degrees of flexion to keep a bit of tension on it. And in the case of the transverse fracture, there is an increased risk for avascular necrosis. Rehabilitation following a fracture of the patella is dependent on the severity of the fracture and if there was an operation required or not. Again, if non-operative management occurs, there will be immobilization in full extension for approximately 4 to 6 weeks. During this time, the immobilizer can be taken off for range of motion exercises and submax isometrics. Rehabilitation following operative management of a patellar fracture is depicted on this slide. Again, they may present with a knee immobilized at 20 degrees flexion, and a lot of times this immobilizer can be taken off for activities. 1 week post-operatively, it's appropriate to do active knee extension, submaximal quad sets, and straight leg raises. However, we may want to limit knee flexion for up to 6 weeks to allow bone healing. Full weight bearing should be achieved by about 6 weeks, and then the focus is on normalizing gait through closed kinematic chain step-ups and squats, as in non-operative management. Supracondylar fractures of the femur are another classification of fracture in the lower extremity. These fractures can be classified as extra-articular, unicondylar, or bicondylar. They are usually treated with ORIF and are non-weight bearing early on, with limited weight bearing for up to 8 to 12 weeks. In your slide you can see some examples of ORIF procedures. Complications with these type of injuries include vascular injury in the popliteal region, and this causes arthropibrosis and quad adhesions. Early rehabilitation includes patellar stretching within the confines of the immobilizer, quad sets, straight leg raises, and active knee flexion as allowed. As bone healing permits, weight bearing is progressed, and at the end of rehab, we are using close kinetic chain activities and strengthening activities to return to full function. We can also fracture the proximal tibia. A common tibial fracture is a tibial plateau fracture. If these fractures are non-displaced, they're treated conservatively, and if they're displaced, an ORIF procedure is used, and you can see examples of ORIF procedures on your slide. With rehabilitation following an ORIF, there's early quad sets, straight leg raise, ankle pumps, hamstring stretching, and other activities. With both of these, the person will be non-weight bearing initially, and weight bearing will be progressed slowly. Now let's discuss total knee arthroplasty as seen in your slide. Here's the surgical procedure and here's a picture of the result. Many of you have seen these. These are indicated for use when somebody has advanced osteoarthritis. So they have medial, lateral, and/or patellofemoral degeneration. These are also indicated for use in people with rheumatoid arthritis with similar cartilage destruction. They're contraindicated for use in the presence of active or recent septic arthritis, a non-functioning extensor mechanism, or someone with severe neurological dysfunction which prevents control of the knee. These are typically seen in people 60 years or older with osteoarthritis, but if someone's younger, it's often due to rheumatoid arthritis. The goals of a TKA are to relieve pain, uniformly transmit forces across the joint, create a horizontal joint and stance phase, restore mechanical and anatomical joint accesses, provide adequate stability, and most of all, improve function. Rehabilitation following TKA is dependent on the type of prosthetic implant. A constrained or conforming implant is one that sacrifices the ACL and PCL and relies on the device for stability. This is the one typically used. A non-constrained or cruciate sparing relies on soft tissue and the device for stability. This would be used for someone younger and more active. Also, other things to consider: is it fixed weight bearing? So is there a polyethylene component fixed to the tibial tray, or is it a mobile weight bearing where the polyethylene platform articulates between the femur and the tibia? In theory, the mobile weight bearing allows for better load sharing throughout the polyethylene and theoretically reduces wear on the implant. In all cases, there will be patellar resurfacing with a plastic button. All four show similar results, although there is increased osteolysis with the mobile weight bearing. Also to be considered, is it cemented or non-cemented? Cemented is usually used but may loosen over time in active patients. So this is typically reserved for the older patient that is not extremely active. Non-cemented have porous holes in them which allow bone to grow into the device, so there's a direct biological fixation. This is used for younger people that are far more active. So rehabilitation following TKA is dependent on whether it's cemented or non-cemented. With cemented, there's weight bearing allowed very early. With non-cemented, weight bearing is deferred for several weeks. When you see these immediately post-operatively, you'll see a compression dressing with an immobilizer in an elevated position. During the maximum protection phase, we want to reduce unwanted stress, but we also want to stimulate muscle strength, range of motion, and decrease pain and swelling. Remedial exercises include quad sets, ankle pumps, glute sets, active assistive range of motion, straight leg raises, short arc quads, and supine heel slides. CPMs are also typically used in the acute phase. Again, weight bearing is dependent on the fixation device, but usually partial weight bearing immediately. We also want to perform patellar stretching to avoid adhesions, and we progress rehab as tolerated to more difficult exercises. In addition, because these are typically elderly people, general rehab for cardiovascular fitness is important. Now let's look at a high tibial osteotomy. This is performed for patients with severe compartment degenerative joint disease. The medial compartment is the most common, and the person displays with bow legs. As you can see in your slide, a wedge of bone is taken out to make a more vertical compression between the femur and the tibia. So it's not so one-sided to one compartment as we see here where the arrow's pointing here. This is considered a temporary solution for approximately 7 to 10 years. The procedure distributes forces and compressive loads more evenly, and this is more successful in patients under 50 years of age with at least 120 degrees of knee flexion. So as you can see, this is used for a younger individual to delay the need for total knee arthroplasty. Rehabilitation following high tibial osteotomy is similar to that for total knee arthroplasty, and weight bearing is dependent on healing. Usually, there's touch-down weight bearing or protective weight bearing for up to 12 weeks. In addition, progressive exercise is initiated gradually within the first 3 to 4 weeks. Once bone healing is confirmed by X-ray, weight-bearing status is increased, and therapeutic exercise is progressed as tolerated. And finally, you will want to review the common mobilization techniques found in your book. There's tibiofemoral distraction, anterior glide, and posterior glide, and there's also patellar glides, caudal, cephalic, medial, and lateral. So review those in your book, and we'll go over those in the coming weeks. So in summary, we looked at management and rehabilitation of knee ligament injuries, meniscal injuries, patellofemoral disorders, common lower extremity fractures, total knee arthroplasty, and tibial osteotomy.